Hello, everyone. Sorry for being 2 minutes late. We were having a side discussion, and we wanted to thank you for being with us today on the webinar around exercise. I'm going to start by a quick introduction. My name is Hind Alamuddin. I am the HCP Marketing Manager at mylife Diabetes Care, and I'm happy to host today Professor Otmar Moser, where he will be presenting the topic of exercise and diabetes with mylife Loop powered by mylife CamAPS FX. So we are going to run this webinar a bit differently. We're going to try to make it as interactive as can be. So if you do not mind, while Professor Otmar is presenting, you can share with us your questions in real time using the questions icon on the bottom right. And I will be interrupting Professor Otmar with your question. I have already asked for permission to interrupt, so all good. We will be having a question session at the end. So if you would like to keep your question to the end or during the presentation, both would work for us. So without any further ado, Professor Otmar, please go ahead.
Hi, everybody, and a very warm welcome from Austria, from Graz. It's already 5 p.m. with us, so I hope you grab already an espresso or a coffee, and we're having this presentation and conversation together. I need to say I feel very much honored that so many people are within this call, within this webinar. It's a sincere pleasure, especially it shows the importance of the topic type 1 diabetes and exercise when using the myloop powered by mylife CamAPS. So I'm very happy that you are all in, and let's have now a chat together. Please feel free to send all your questions, and I try my very best to answer all of them. But as I know that around 1,000 people have been registered, I might not be able to answer all of them. So this is my conflict of interest. So what are we going to discuss today? So we will be discussing this love-hate relationship between type 1 diabetes and exercise. We will have a focus afterwards on the ESD ISPED position paper on AID and exercise. I will show you some very novel evidence we collected in our lab on the mylife Loop CamAPS system and exercise. I will show you specific case studies where I look forward to have your thoughts on solutions, how we can overcome dysglycemia when using the mylife CamAPS system around exercise. And I will give you a short and quick future perspective and a conclusion on the topic we are discussing today together. So what is the background? And most of you people do know that. So the main reason why children and adolescents and those parents and adults with type 1 diabetes are not regularly exercising is clearly known of fear of hypoglycemia. So this is so interesting to understand. Even parents of kids living with type 1 diabetes are afraid of hypoglycemia. And this is very important to understand. So with the diagnosis, we really need to focus on the fact to have a nice education, a proper education going down the route of exercise and type 1 diabetes. Secondly, people with type 1 diabetes are afraid of hyperglycemia. And this goes hand in hand when using CGM. 10, 15 years ago, we did not know that most of the people living with type 1 diabetes are starting with glucose levels above the 250 milligram per deciliter. And then they're constantly falling. So people do now see those days what is going on with glucose, and they like to avoid hyperglycemia around exercise. And last but not least, loss of diabetes control is also a major Achilles heel for those living with type 1 diabetes. They are afraid the time in range is going down and HbA1c is going up due to exercise. But to be honest, this has nothing to do with exercise. When HbA1c is deteriorating in people who are regularly exercising, this does solely mean this is a mismatch between carbohydrate intake and the exogenous insulin amount circulating. So it must be clear we need to balance the exogenous insulin dose and carbohydrate intake, and at the same time the exercise amount. And this is the first slide. Some people of you might know from the ESD ISBET position paper. So we were discussing the average glucose response to exercise. And for the majority of people with type 1 diabetes, you should expect a drop in glucose, especially for low up to moderate intensity exercise. We would be mainly expecting a glucose drop. However, for very high intensity exercise, so very short sprints, for example, or overnight fast and resistance exercise, there might be also seen a slight increase in glucose levels. What about the insulin, the exogenous insulin requirements? This is clear, and this holds also true for the modern automated insulin delivery systems. If glucose is going down, we need to lower the exogenous insulin amount. However, if glucose go up, we need to go up with the exogenous insulin dose. How could that be done when using the mylife CamAPS system? For example, losing the boost mode or going down with the glucose target, because this will result in an increase in insulin delivery around exercise if this is needed. Last but not least, we do give specific recommendations on the carbohydrate intake. So this does mean if glucose is fast dropping, we need to consume high amounts of carbohydrates. However, at the same time, we do not need any carbohydrate intake when glucose is going up. So from our perspective and from my perspective, we do not like that so much when a person with type 1 diabetes is using an AID system to constantly, for example, every 15 minutes consume carbohydrate. We prefer defining in advance to exercise a threshold, for example, 126 milligram per deciliter, so 7 millimole per liter. And each time when a person living with type 1 diabetes is going below this threshold during exercise, a specific amount of carbohydrate is recommended based on the velocity and the drop in glucose. And these are very novel data. So we just submitted the revision for this publication, which was submitted to Diabetologia. We just did present the data during ESD conference and a separate set of data during ADA conference. And this is the largest trial ever performed in people living with type 1 diabetes. And I'm happy to show you. So we have here in total above the 420,000 exercise sessions of 3,200 individuals living with type 1 diabetes. And as a first step, we were assessing when was exercise performed and when do people with type 1 diabetes have the highest risk of hypoglycemia. So this looks now very confusing, but it isn't. Look at the y-axis. There you see when the exercise session was performed. And as soon as it's getting dark afterwards, this does mean there is an elevated risk of hypoglycemia. So what do we see here? People with type 1 diabetes who are doing morning exercise sessions do not have an elevated risk of hypoglycemia at all. However, at around 11 a.m. when exercise is performed, we see a first increased risk of hypoglycemia at around 12. And we see it through the entire day. So what do we know from our data? We do not face this real problem with hypoglycemia during exercise, but there is a massive elevated risk of hypoglycemia in the first hour after the exercise session. And very interestingly to see, if someone with type 1 diabetes is doing exercise in the evening, this person has the first hour after the exercise session an elevated risk of hypoglycemia, and additionally at around 2-3 a.m. during the nocturnal period, there's again an increase in the risk of hypoglycemia. So what does that mean? If you have a patient in support living with type 1 diabetes and has in general an elevated risk of hypoglycemia, do not recommend evening exercise because there is a second increase at around 2 a.m. in the morning of exercise-induced hypoglycemia. So very interesting data. So what do we know from these data? It's not in exercise a problem. It's the first hour after the exercise session. People with type 1 diabetes are struggling with hypoglycemia. And secondly, during the nocturnal phase, so around at 2 a.m. in the morning, is again an elevated risk of hypoglycemia when evening exercise was performed. So what does that mean for the mylife CamAPS system? First of all, what we learned from the data was exercise mode. So for example, the ease off or the increased glucose target should stay started for another hour after the exercise session, or even let it roll for 2 hours, even the exercise session has already stopped. If someone is doing, for example, exercise at 9 p.m., maybe you stay the ease off on, switched it on for another 4, 5, 6 hours. So this is our learning from this study. But let's go more into detail and look what's happening during exercise in people with type 1 diabetes in close to 420,000 exercise sessions. And this is the acute response to exercise on average in people living with type 1 diabetes. What do we see here? For the majority of people with type 1 diabetes, independent of the exercise intensity. So if it's walking, if it's aerobic exercise or anaerobic exercise, we see a drop in glucose. There might be a few people out there that have an increase in glucose. But in general, independent of the exercise intensity, glucose is dropping. But during exercise, the lowest drop is seen during anaerobic exercise. But interestingly, with anaerobic exercise, you see around 3 hours afterwards, again, a drop in glucose. So again, very interesting data I'm allowed to show you already. They have recently been presented last week during ESD conference, but major learnings can be taken from these data, from the acute response and from the long-term response to exercise. So when do we face an elevated risk of hypoglycemia, so levels below 70 milligram per deciliter, so 3.9 millimole per liter. And it's very important to understand, so what is the main reason for exercise-induced hypoglycemia? And my dear friend Mike Riddell from Canada did analyze that in the T1DEXI study. And he was mainly checking what was the main driver for exercise-induced hypoglycemia in people with type 1 diabetes, independent on the type of therapy. So it could be some patients using an AID, it could be some patients using a traditional CSII therapy. And the main driver for exercise-induced hypoglycemia is not exercise. It's insulin on board. So it would be, to be honest with you, wrong saying it's exercise-induced hypoglycemia. To be honest, it's exogenous insulin-induced hypoglycemia in combination with exercise. Additionally, it's known if a patient with type 1 diabetes have a fall in glucose before exercise, this person has an elevated risk of hypoglycemia during the exercise session. Additionally, the time of day, and think back to the first slide we have seen. So morning exercise has in general a very low risk of hypoglycemia, but evening exercise has an elevated risk of hypoglycemia in the first hour after the exercise session and around 5 hours after performing the exercise session. So keep in mind, discuss always with your patients that insulin on board should be kept as low as possible. How could that be achieved? Starting the ease off mode in advance to exercise as early as possible, or go up with the personal glucose target as early as possible to lower the amount of insulin circulating physiologically within the body. So it must be clear we need to play with the settings when using an AID system to achieve very good results. And the very good results are clear, to be honest. And this was a nice study performed where they investigated steps per day, and if the steps per day have an influence on glycemia, so CGM-derived metrics. So there were three groups built. One group was walking below 7,000 steps, the other group 7 to 10,000. And they are the real exercise nerds. They were walking above the 10,000 steps a day. And what do we see here? For insulin pen therapy and insulin pump therapy, you see an increase in risk of hypoglycemia when people are walking more steps a day. We see the same for pen, we see the same for pump, but let's focus now on automated insulin delivery on AID systems. Automatically, we see this improvement. So it must be clearly said, don't be afraid to prescribe your patients an AID system when they are not running on one, because when they are exercising, glycemia will be better. Time and range during exercise will go up. The time below range will be lower, and additionally, the time above range will be lowered. So even for physical activity, AID systems are much better working than traditional insulin pen therapy or traditional non-automated insulin pump therapy. And this was nicely investigated and published a couple of months ago. But now let's focus.
Professor Motor, I'm going to interrupt you, sorry, as I promised.
Yes,
we
that's
have
cool.
2 questions, if you don't mind.
Go for
What
it.
would be the pathophysiological explanation that there is less hypo in the morning? Is it just the fasting exercise?
It's not the fasting exercise. Am I allowed to answer already?
Yes, go ahead.
Yeah, it's not the fasting exercise, because some people, or the majority of people in this study, also went for a morning insulin dosing. So we do mainly see when people are waking up early, the cortisol levels are going up, so the Dunn phenomenon. At the same time, you have in the morning the slight increase in catecholamines levels, so adrenaline and noradrenaline. And what is the real function on that? Also in the type 1s, you have the hepatic glycogen depletion. So from our perspective, we do see in general that people with type 1 diabetes have an endogenous insulin production that is elevated in the morning. And from our perspective, this is a trigger not jumping into exercise-induced hypoglycemia during the morning phase. So cortisol, catecholamines, focusing on hepatic glycogen depletion. And quite often, to be honest, people are sleeping over the nighttime period. So no intramuscular glycogen depletion is going on during the nocturnal period. This might be further supportive to avoid hypoglycemia in the morning phase.
Okay, we have 2 other questions. How early is as early as possible? Ease off.
We will lose ourselves into detail in the following 2 slides. So I do not answer this now. But I give one answer, maybe, for example, if someone is going for a run over 6 hours and we are supporting people doing this, we are recommending for such a long duration of exercise, going up with the personal glucose target already 4 hours in advance to the exercise session, and starting also the ease off in the mylife CamAPS system 4 hours in advance. So the longer the duration of exercise, the earlier it's quite good to start the ease off or going up with the glucose target.
Mm-hmm. Another one, is there a cutoff level for insulin on board to be safe or unsafe?
Difficult to answer. Really good question. We are analyzing that also relativized to body weight. And from that perspective, it's difficult to give a clear information. So what we are doing at the moment, we are calculating the total daily dose within 24 hours. Then we are calculating it per hour. And then we are assessing what is the insulin on board when people are exercising and having no hypo. From the tradition, we know it should be aroundish 50% of the regular insulin on board to be safe, but it's even less than it's preferable.
Okay, one more question and then you can proceed. On the subject of fear of hypo/hyperglycemia, what advice would you give to a 20-year-old man who experiences hyperglycemia when playing soccer, reaching levels of up to 20 millimole per liter, and who experiences hypoglycemia after physical exercise? How to manage insulin intake?
This is the difficult one. So we have a small percentage of type 1s that they're constantly afraid of hypoglycemia. So, for example, they have hypoglycemia symptoms at around a 10 millimole per liter, so 180 milligram per deciliter. So what I have learned over the last 6 years when having this specialized outpatient clinic for exercise and type 1 in Graz was that we are must absolutely individualize the glucose targets during exercise. So majority of people are recommended to have a glucose target of around 150 milligram per deciliter or 8.3 millimole per liter around exercise. But for such a person who is so afraid of hypo, I would do the following. 4 hours in advance, I would go up with the glucose target to a 200 milligram per deciliter. Additionally, start the ease off 4 hours in advance. I would try that for 2 or 3 months, and then I discuss with him within the next months, you go down with the glucose target to 180. Within the next 3 months, you go down to a 160, but still leave ease off on. So we have this stepwise approach over a period of 1 year to bring this person down with the glucose target, and at the same time for post-exercise hypoglycemia, as you were explaining in your question, then I would say then stay on the elevated glucose target and additionally start ease off. And here the same procedure as a stepwise approach, go down with the glucose target over a period of 1 year. Am I allowed to go on?
Yes, go on.
Perfect. Please ask your questions. This is where I learn most, to be honest, and I also want to learn something today. So this
Mhm.
is the ESD ISPED position paper. Most of you people know. I give you now some insight, what you might not find within the position paper. So I give you some thoughts, how we developed it, and why we have certain recommendations. Please ask your question. I'm more than happy to answer them. So it's dually published in the ESD, in the Diabetologia journal, and at the same time in the ISPED journal and Hormone Research in Pediatrics. So for all the AID systems available, we give specific recommendations how to start the so-called exercise mode, and we will be here discussing it for the mylife CamAPS system. So for the mylife CamAPS system, you have these two functions. You have the ease off and the boost. The ease off is decreasing the algorithm responsiveness, and the boost increases algorithm responsiveness. And there comes a very important point. As soon as you start the ease off or the boost, this is not included in the algorithmic learning. So it's a perfect choice for irregular exercise. You know these people that are, for example, every 2 weeks going out hiking over 6 hours. Recommend these people start early enough, maybe 2 hours in advance or 4 hours in advance, the ease off, go up with the glucose target. Very important to understand, if you do both, if you go up with the glucose target and at the same time start the ease off is always taking care that it's not included in that extent in the algorithmic learning. What is the other option? So to define a very specific value that the system is trying everything to achieve this value around exercise. So this is now shown how to start the personal glucose target. You have the options between 4.4 to 11 millimole per liter, so 80 to 198 milligram per deciliter. And this is included in the algorithmic learning. It's the perfect choice for regular exercises. So if you have someone who is every day at around 5 p.m. in the afternoon doing an exercise session, starts 2 hours in advance, going up with the personal glucose target, for example, to a 150 milligram per deciliter, and then this is included in the algorithmic learning. So it's perfect using this for regular exercises. Very important to understand, as I said in advance, if you do both ease off and going up with the glucose target, it's excluded from the algorithmic learning. So these are the two options. And we must be honest, for the mylife CamAPS system, this is the only opportunity to have this extreme wide range of personal glucose target. So what does that mean? If you have an exercisey person and this person is doing, for example, different types of exercise, you can define based on the expected glucose response different glucose target, and then you will see you're achieving 100% time and range during the exercise session. And now let's lose ourselves into very much details. So this is the information what we give people with type 1 diabetes. Normally they do it that way. They make a photo on the mobile phone of this figure when they go out for a run, then they zoom into it with a specific question, they find the recommendations, and this is how they use it. So for plant exercise or for plant activity, we do recommend at least 1 hour, but ideally 2 hours in advance of the exercise session, starting the ease off and or going up with the personal glucose target, for example, to a 150 milligram per deciliter. What can be done if needed for the prandial insulin dose? For the prandial insulin dose, if someone is expecting to go low during exercise, reduce the prandial dose by 25%. What should be done for someone that is always going up, and this is a very small group, then we recommend stay on the regular glucose target, or at the onset of exercise start boost or go down with the glucose target. What should be done for spontaneous exercise? So my wife is giving me a ring and she is saying we go now out for a bike within the next 10 minutes. The first thing what I do is immediately start ease off and go up with the glucose target. Then I check if I'm below the 126, I consume 10 up to 20 grams fast acting carb. And now a very important information, all the carbs directly in advance consumed before the exercise session should be filled into the system as hypoglycemia treatment. And also all the carbs consumed during the exercise session should be filled into the system as hypoglycemia treatment, even it's not a hypoglycemia. Why? Very easy to understand. The first response is nothing. The mylife CamAPS system is then waiting for exactly 30 minutes where no further insulin is delivered, even though carbohydrates were consumed. Secondly, then there's a first choice. Is insulin now needed after 30 minutes, yes or no? And is it needed exactly based on the carbohydrate amount consumed, or is less needed, or is no insulin needed? So this is why we preferably use hypoglycemia treatment also during exercise. For unplanned exercise where you expect you're going up, again, stay on the regular glucose target, or even when needed, start the boost mode at the onset of exercise or go down with the glucose target. What should be done during exercise? Threshold is 126 milligram per deciliter, so 7 millimole per liter. And if someone is dropping extremely fast, then we recommend 12 up to 20 gram carbs to be consumed. If someone is dropping slightly and is below this threshold of 7 millimole per liter, so 126 milligram per deciliter, it's 6 up to 12 gram carbs. And if someone is very slowly dropping, we recommend 3 up to 6 gram carbs. What should be done if someone is exploding during the exercise session, is going up? We recommend maybe start in between the boost or go down with the glucose target. How often are the carbohydrates needed? As often as needed physiologically. So this does mean if someone is exercising for an hour and this person started with a 150 milligram per deciliter, and after 13 minutes he's going down to a 113, so below the 126, then he's consuming, for example, 12 gram carbs. This person is going up again. Then after 20 minutes, there's again a slight drop. Then he or she is consuming 3 up to 6 gram carbs. So there can be exercise sessions where you need to treat 10 times, and there might be exercise sessions where no carbohydrate at all are needed. So I hate giving very standardized recommendations. So it's absolutely dependent on the person and what type the person of exercise is doing. So just say threshold 126, when you are below, consume carbohydrates based on the velocity and the drop in the glucose levels. So this is a recommendation how we use it. As a first recommendation, we are giving these numbers, and then it must be further individualized.
We have a question.
Yeah.
Okay, so can you clarify how much you recommend to increase the personal target by before exercise?
It's depending. In general, we go in as a first recommendation, setting the glucose target to 150 milligram per deciliter, so 8.3. However, if you have someone who then needs to constantly eat carbohydrates, then we say, for example, start it already 3 hours in advance and go up to a 180 milligram per deciliter with the glucose target. So as you hear, there is no general recommendation, but as a first recommendation, I would always be saying 2 hours before the exercise session, go up to a 150 and additionally start the ease off mode.
Okay.
Am I allowed to go on?
Yes.
That's cool. So let's focus on some evidence. Some of them are already published, some of them are under revision at the moment. So this is just a small example where we used a couple of kids. Now the study has already finished. So it's 30 kids in total. And these kids performed the maximum incremental exercise tests. What did we do? 2 hours before the exercise sessions, we went up with the glucose target to a 150 milligram per deciliter, and additionally, we started to ease off. So what is happening here? There you see the lactate response, and this is quite cool, to be honest, because the youngest were 8-year-old. And how did we achieve this massive lactate response, close to 10 millimole per liter? All of the small kids were allowed to watch Netflix or YouTube. Otherwise, it would not have been working, to be honest with you. But most interestingly, let's focus now on what was happening with the glucose. Nothing. And this is perfect. So glucose stayed constantly stable. And there's one mistake in this line. It should be around 30 milligram per deciliter lower. And this goes back to me, to be honest, because we did not know in this very early study we performed already 2 years ago. We have started with that. And we should have been only recommending glucose target of 150 and not using the ease off, and then it would be a straight line on the 150. But this clearly shows even during a maximum incremental exercise testing with kids with type 1, glucose stays stable if you start 2 hours in advance with a higher glucose target. Here's another one, and this now goes back to the information of prandial insulin dose reduction. So there we compared, is it necessary in kids with type 1 that they reducing for constant load, moderate intensity exercise the prandial insulin dose by 25%. And these data we just received after publishing the ESD position paper. So it was a crossover design. Once they came in with a full prandial insulin dose after a standardized meal, and the other time they went in with a 25% reduced dose. However, for both conditions, the glucose target was set up to 8.3, and the ease off was started 2 hours in advance. What is happening here? Nothing. So this is clear information. It looks like for the mylife CamAPS system, pre-exercise prandial insulin dose reduction is not needed. The only difference was they started higher, so in the hyperglycemic range when I reduced the prandial insulin dose, but at the end, it was the same dot at the end of the exercise session. So it was a perfect line otherwise. So we had no hypoglycemic event during 1 hour of exercise. And for this exercise, no additional carbohydrates were needed. Another one, Sabrina did perform this study, a member of my team. We also were interested in adults with type 1 when they do a resistance training, or here's maximum strength testing. So what did we do here? So we learned already from the previous data, and there we solely went up to a 120 milligram per deciliter with the glucose target, started the ease off, and 2 hours in advance both was performed. Afterwards, for around this 1 hour, strength test was performed. What do we see here? Starting glucose in mean was around 130, and end glucose after the exercise session was also around 130. So it's cool to see it works for kids during incremental exercise testing. It works for postprandial exercise with constant load, and it also works for resistance exercise. And this is why I did say before, ideally 2 hours in advance, you need to change the settings in the pump, then it's working quite well. And now I'm allowed to show you some very novel data, because we were the first ones showing also the insulin delivered automatically under pre-test conditions, during the test and after the test. And what do you see here? People were running aroundish on a 6 units per hour during before the exercise testing. Then before the exercise testing, when they started, they ease off and lowered the glucose, started automatic insulin delivery immediately went down. And then very interesting to see, during the strength test, insulin delivery slightly went up. This has to do with the catecholamine response to strength training. And under post-exercise condition, the system recognized, okay, glucose would go up. Now I go up with the automated insulin delivery. So very interesting to see how the system is regulating glucose autonomously during the exercise session. Last data from evidence, really nice data, 19 kids with type 1 diabetes running on different AID systems. A couple of them were also running on the mylife CamAPS, and they were exercising. We were here at the ski camp in Austria over 2 days, and per day 2 times 2 hours. So it was 4 skiing sessions in total. And we started, this exercise mode 2 hours in advance. We compared glucose before the camp, in the camp, and after the camp. Perfect data, to be honest, because there were no significant differences. So it must be clearly said, even for an extreme type of exercise, going skiing at minus 12 degrees, how it was like, the mylife CamAPS system works quite well to stabilize glucose, and it's no difference when they are at home, when they are in ski camp and sleep there a couple of nights, or after the ski camp. So we are very happy. And look here at the time below range, below 54 milligram per deciliter, even during the camp, the lowest numbers of hypoglycemia were seen. Now, let's focus on some cases to cool down a little bit, and additionally to answer your questions afterwards. So this is a nice case. We always use the landscape. In the blue line, you see the automated insulin delivery. Here at the top, you see the carbohydrates consumed combined with the insulin injected as a prandial insulin dose. If you see, like here in the middle, only carbohydrates, this does mean it was delivered as hypoglycemia treatment. So what did this person do? Ease off was started at around 30 minutes in advance before walking with the dog. So this must be sufficient, to be honest, if it's a short duration walk with the dog. What was happening here? At a 5.3 millimole per liter, because 6.0 millimole per liter we defined with her, 5-gram carbohydrates were consumed. They were filled into the system as hypoglycemia treatment, and in this case, it worked extremely well. But this is not always the reality, to be honest. So let's focus on a different case that it's more important, when the husband is going with his wife for shop. So this is the classical situation where we see an exercise-induced hypoglycemia. And to be honest with you, he did prepare himself. Let's check it. He did twice a 25% prandial insulin dose reduction. Afterwards, he did see, oh my God, I'm going up. So he was starting then the boost mode, because he was over the entire day running high. Afterwards, he was afraid that he's going into hypo. So he started the ease off. And to be honest with you, what should have been done here? Quite easily, go 2 times for a regular prandial insulin dose, and if needed, start at the onset of the shopping session with your wife, the ease off mode, and this should be sufficient. This person was simply a little bit overreacting in the prandial insulin dose. Now let's focus a little bit more on exercise. And this is a session. This is Theodore Theo, who is 24 years old, has a good HbA1c of 6.7, time in range of 82%, and he's always struggling when he's doing his cycling session. So he's going between 2 up to 4 hours on a bike ride. Normally it's 3 hours on the postprandial condition, and his regular glucose target is on 4.8. What is he struggling with? Constant hypers, and he needs to consume around 80 gram carbs of per hour of exercise, and he would like to avoid this. So let's focus on his trace, and this is one example. What did he do there? He was checked in a regular prandial insulin dose, but he has not a big interval between the interjection and starting to eat. So this must be clearly said. It's very important for the mylife CamAPS system to leave at least 5 minutes space between going for the bolus dosing and starting to eat. And why is it especially important for pre-exercise conditions? As you see here, if you start to eat immediately after going for a prandial dosing, the automated insulin delivery goes up. If he would have been waiting a little bit longer, we would have been seeing less insulin automatically delivered. What is he doing then? He's starting the ease off mode, but he stays on a regular glucose target. Then he's going into a hypo, into a nice hypo with 3.5 millimole per liter, and check what he's doing afterwards. 20 gram carbs without insulin, 12 gram carbs, 60 gram carbs, 15 gram carbs. Okay, then he's seeing on the post-exercise condition, he's going up and he's going for insulin injections. And what is he doing at the end? Additionally, he's going for a manual insulin dose correction. So let's discuss what we discussed with him. So what are the options for Theodore? So we were discussing for him reducing the prandial insulin dose for pre-exercise conditions, starting the ease off or increase glucose target a little bit earlier. Very important, longer bolus to meal interval. This is fixed by him already, and not consuming carbohydrates at the 3.5, already consuming it at the 7.0 threshold as discussed before. Let's see if it's working. To be honest, it was working quite well. So what did we do? Quite easy. We went for a bolus reduction, and additionally, we went up with the glucose target to a 150 milligram per deciliter, and to a 7 millimole per liter, so to a 130 milligram per deciliter, and additionally, we started the ease off mode. When did we do that? Aroundish 2 hours in advance to the exercise session, but the glucose target was already started earlier. Very interesting to see here. He knew what is happening. So he was treating hypoglycemia in advance before it occurs to avoid the hypo with 23 and 15 gram carbs. Even he was running on a 160. So quite early proactive treatment, and it worked quite well. We are happy with this one. He again afterwards started the ease off to avoid hypoglycemia. And to be honest, for such a long duration of exercise, we are absolutely happy. So this person was on the bike for 4 hours, and he consumed carbohydrates 4 times, which is totally fine. And he started ease off twice. So perfect situation for someone specialized like Theodore. Let's focusing on the last case, and then I will give you a slide information what we are working on at the moment for our future work, and additionally having a small conclusion. So this is Kilian. Kilian is aged 38 years old, is type 1 since 2000. HbA1c is nice, 6.5, time in range close to 90%. And he's doing, his 3 times a week gym sessions, but very interesting, at 5:30 in the morning, overnight fasted. Normally, he has a regular glucose target of 5.8, and he is having roller coaster during the exercise session. So, if I would be forced to do exercise at 5:30, this would not be working for me. I could only be starting at 9ish around him, but he is fully into it, as you see via his musculature. Let's focus on it. What is happening here? 5:30, he's starting with exercise. What is he doing afterwards? 1 hour after the exercise session is already running. He's starting the boost mode because he's extremely running high. Additionally, he's going for a manual bolus correction. We don't like that too much. We have always this attitude, let the system roll, it's regulating in automatically. So this is a classic case where you see this person is not proactively avoiding hyperglycemia exercise. Another example of Kilian. What is happening here? When he is already running high after 1 hour of exercise, he's starting to boost mode. And what is happening then? He's going into hypo around or under post-exercise conditions. He's treating it with a whole lot of carbs, but simply too late. So what do we see here? Someone who is always running into hyperglycemia, starting boost mode too late, and in some situations running followingly into hypo. So what are we discussing with him? What are the options of Kilian? Lower glucose target at the onset of exercise. Secondly, we discussed with him treating hypoglycemia before it occurs, so at the 126, set boost mode at the onset of exercise, and having a low intensity warm up. Why low intensity warm up? To activate glucose transporter type 4 that lower glucose levels without insulin. So what did happen? What did we do with him? As you see here, exercise session worked quite well. What did we do? We did discuss with him quite easily 10 minutes low intensity warm up, not just going in with weights, do a low intensity warm up to activate glucose transporter type 4 to overcome this increase, and additionally, at the onset of exercise, go down with the glucose target to a 4.4. So two easy recommendations, as you see here. Glucose during the exercise session was a perfect line, so we are absolutely happy with him. So these are now my two last slides before we can have still a chat. So what are we working on? We are working on an automated detection of exercise. There are some data outside that did show that exercise can be detected automatically. We are coming closer to assess via the skin cortisol levels, to have this option, when cortisol is going up massively with combined a low heart rate, you would expect an increase in glucose, versus when both go up, you would expect a decrease. So these are just numbers we are playing with. And we also have the idea of having just a mobile phone or just a smartwatch on the arm, and everything is arranged via the smartwatch. Maybe also there's still the option of incorporated glucagon within an automated insulin delivery. And for sure, the new insulin, the AT278, might be extremely good in this fully closed loop around exercise. So to sum up, the mylife loop powered by mylife CamAPS offers such a wide range of opportunities that can be used around exercise. It must be adjusted during the exercise session based the expected response to exercise. So discuss it with your patients. You can give a first recommendations based on our ESD position paper, but to be honest with you, it must be individualized day by day, week by week, month by month by the patient. Additionally, ideally, I would recommend starting the ease off and going up with the glucose target 2 hours in advance. There I made one sentence. I'm not a fan of starting the ease off and going up with the glucose target 1 hour in advance. I prefer always as a recommendation 2 hours in advance to make sure people do not overconsume carbohydrates and they are not afraid of hyperglycemia. Additionally, for spontaneous exercise, yes, this is possible. It must be clearly said, If you are below 126, then carbohydrates should be consumed at the onset of exercise. Additionally, and this is not within the ESD ISPET position paper, it looks like that for the mylife CamAPS system, and this is the only system where it was shown when compared against the other systems, a prandial insulin dose reduction might not be needed. So, dear ladies and gentlemen, dear friends, it was my sincere pleasure being allowed talking to you. And now we have another couple of minutes to answer your question. And if we stay a little bit longer, I don't care. So, hint, you can give me
Yes.
the questions if there are any. And if it takes a little bit longer, I don't care, to be honest. Thank you very much.
There are many questions. I did not want to interrupt you,
Yeah.
but even though you allowed it, so we'll go ahead. I'll try to pick the longer ones to make
Okay.
it interesting. Do you have a suggestion for how to manage post-exercise spikes? Some AID users rebound quite high, 15 millimole per liter or higher, after
Yeah.
prolonged pump suspensions during exercise, and giving correction boluses then can lead to further added hypo risks later. How can we help people prevent this spike with this system?
Yeah. So first of all, there are two groups out there. I'm in the group, always keep the pump on you and not do a pump suspension. Now the question comes, yeah, but when we do football, when we do different types, we try our best that the pump and the mobile phone is still on the person. So we are working with a Schneider and they are developing specific clothes with specific protection that the pump can stay on the person, and additionally also the mobile phone. So this is my attitude to this issue. Secondly, what we do see that also for people who let the pump on, and there we recommend at the last 15 or 20 minutes before the exercise session stops, go down already during exercise with the glucose target and stop the ease off. So even during exercise, in the last third of the exercise session, you can stop ease off, go down to regular glucose target to avoid this increase. Secondly, what we see quite often, for example, if people are playing football, they do not do a cool down. And this is a thing we need to explain to most of the type 1s. Do a 15 minutes low intensity glucose cool down to activate glucose transporter type 4 by at the same time eliminating catecholamine within the bloodstream. So give this recommendation, you will have a benefit. This is what I would recommend.
Okay. We know that carbohydrate sources are diverse. What types of carbohydrates are recommended for consumption? Monosaccharides, complex carbohydrates? What's your opinion on maltodextrins? Thank you.
Yeah.
That's the
So we did a couple of studies where we did compare a monosaccharides or fructose glucose in different settings. So 70% fructose versus 30% glucose, blah, blah, blah. And when we do this threshold-based treatments during exercise, so when you're below the 126 and you're recommending carbs, it must be fast-acting carbs. And we did show in our studies that the fastest carbs are a 50-50% mixture of fructose and glucose, liquidly given, and they are immediately bringing up your glucose. And the cool thing is with the fructose that around 30% are transferred via glyconeogenesis to lactate. So you have, again, at around 1 hour afterwards, a second saver where the transferred lactate is again transferred to glucose that helps you protect you. So this would be my recommendation. I hope this was understandable and not too confusing.
I'm sure it was very understandable. Okay, we have patients that want to exercise without having to ingest carbohydrates. They are gaining weight from all the snacking that is required to avoid lows while exercising. A patient that I'm thinking of is on basal bolus right now, but is deciding on a pump. With Ipsomed pump, would you have a scenario where you could use ease off and targets so that no carbohydrates will have to be ingested while maintaining good good control?
So if you would have been not included the last part of your question, it would have been an easy answer. But to be honest, physiologically, we must be clear. The carbohydrates that are consumed during the exercise sessions are used as immediate fuel. So you would not recommend, you would not store that within glycogen, and when you have an over storage that it's transferred into the fat tissue. So this is always the strong assumption that when I want to lose body weight, I'm not allowed to consume carbs during the exercise session. So this must be clearly said. It's about the other periods of the day we are not exercising. There you need to go down with the total kilocalories. But during exercise, this will not increase body weight. This must be clearly said. We do see that from last investigations also in type 1s.
Okay.
Very important to understand additionally, for sure, it's clear for such a person, I would recommend quite a high glucose target. So even going up to a 180 plus ease off to have low amount of circulating insulin level. But at the same time, I would not like to, let them run on the 200 milligram per deciliter during the exercise session. So say to your patients, carbs consumed during the exercise are good carbs. You will not get any fat tissue via that. And secondly, maybe as a recommendation, start ease off and the higher glucose target already 4 hours in advance, then you don't need to consume carbs at all, maybe.
Mm-hmm. There are 2 follow-up questions to one of your answers. Hi, great presentation. Thanks. Is 50% fructose and 50% glucose mix recommendation just sucrose?
It would be in German Haushaltszucker. It is, but we do it practically. We go to the pharmacy and we are buying one very, how would you say, and clear, very small crystallized fructose and glucose that can be used within that liquid. Otherwise, it's setting down. When you use the normal one, you can buy at the shop. So this is the reason why I always say fructose and glucose, grab it from the pharmacy and do a mixture at home. But you are right, chemically, yeah.
Yes, I think this is maybe the same question. So following up on the previous question, can you give us some ideas of 50-50 mixture of fructose glucose solutions?
So the professional athletes we are supporting, and I'm now allowed supporting again the team Novo Nordisk, professional cycling team with type 1 diabetes. Some of them are using also the mylife CamAPS system. I hope I'm allowed to say that. And to be honest, go to the pharmacy, buy 1 kilogram of glucose, 1 kilogram of fructose, and weight it, give it into it, then you have the perfect dose. But always keep in mind around 30% of the fructose will be going into the bloodstream via lactate.
Okay, we have a lot of questions coming. Can you
I
stay?
have plenty of time. I need to bring my kids to bed at 7 p.m. This is the only thing I need to.
No, it won't take that long. I'll try to choose some. I'm going up in the conversation. You recommend carbohydrate fueling for a threshold of 126 milligrams per deciliter. What about individuals aiming for performance? General guidelines recommend 60 to 80 for endurance exercise. Would that be an issue for type 1 diabetes?
No. So the professional athletes we are supporting, and I don't like that so much, but some of them do it. They want to achieve around 120 up to 150 gram per hour of exercise of carbohydrates. Mm-hmm. So this can be easily dosed when you change the setting. So how can you change the setting? If you start ease off and go up with the glucose target, for example, 30 minutes in advance to exercise or 1 hour in advance to exercise, you might be consuming much more carbs as compared to if someone is starting in 4 hours in advance to the exercise. So it must be clear, if you're working with a patient who is an athlete, you can play with the timing of when to start ease off and going up with the glucose target. The closer it is to exercise, the more carbohydrates will be needed during the exercise. If you started 4 hours in advance, more or less no carbs are needed. But at the same time, I'm sorry, I need to give now more details. We do always recommend doing the previous day glycogen refilling. And for the body per se, it doesn't matter if it's orally delivered carbohydrates, so glucose to the musculature, or if it's via the storage. So always try to balance always with glycogen refilling from the previous day.
Okay, there are two questions that are quite similar. How could someone doing contact sports keep the pump protected? Is there any tip, wearables you advise?
So we are going to a Schneider and they are building specialized cases, for example, within their suits with a hard case and a soft case where the pump is in, for example, maybe also within the inside of the leg, for example. And we do the same with the mobile phone. So there's one mobile phone existing, I'm not saying now the name, that looks like these very old, very small mobile phones where CamAPS is able to be running on, and you can use it also on your body when you're doing contact sport because it's so small. So this is how we do it. We build within the clothes a hard case, additionally a soft case. We do the same on the skin, that the patient is safe and the competitor is safe. And this works quite well, to be honest. So in 1 year, we have around 3 up to 6 broken bumps, and we are supporting in total 100 athletes with type 1. But the majority of people are normals with type 1, like me.
We are getting a lot of comments that this is a great presentation. So I feel like I need to share most of the comments are around this direction. And a lot of people saying that they're learning, that they learned a lot. A lot are asking if this is recorded. The answer is yes. So whoever is registered to this webinar will automatically get the recording afterwards. I'll ask a few more questions. What should be expected of mixed aerobic and resistance exercise and net glucose decrease or increase?
Difficult one. So this is a very theoretical question because we see both. We see in some stable glucose when you do 30 min of endurance exercise and 30 min of strength training. We see in some stable glucose, and in some of them we see dropping glucose. But for the majority, we do not see an increase in glucose. So physiologically, you have this combined effect again of adrenaline and noradrenaline at the same time by activating glucose transporter type 4, increase in insulin sensitivity. So you could expect dropping to stable glucose, but with this combined exercise, in general, not a massive increase in glucose. This is what I know from experience, what we do see mainly in the outpatient clinics.
Okay, we're still getting a lot of compliments. I don't know if you want to go through them all. Really great presentation, clear, concise, fantastic work. So I'm trying to read through to get to some questions I can ask.
Totally fine.
Okay. Okay. Isn't there a risk of ketoacidosis when the pump, because of the questions, it bounced. Isn't there a risk of ketoacidosis when the pump isn't in ease off for a long time because of too low insulin dose?
No. Mainly for two reasons. First of all, you always have this slight increase constantly, even when you are already on the borderline to be low, that the insertion said the insertion of the insulin delivery is kept open. So there's always slight amounts delivered. Secondly, after a certain period of time, you will be needing insulin autonomously. So I give you an example. So we did support 2 weeks ago, 1 week ago, quite a professional athlete with type 1 diabetes, and he was running over the Alps for 7 days, 6 hours a day. And he was using the mylife CamAPS system. And what we did see was clear. he was at a certain stage, the automated insulin delivery was completely stopped for 2 or 3 hours. And then glucose slightly went up, and then insulin delivery immediately went up to stabilize him. He went not again into hypo. We did all.
You are muted. I think you. Yes, now
This,
you're good.
this is always the same when you talk about technology. The technology on the computer is not working. No, and what we did see, and what we didn't show so far, we did also measure 4-hourly his ketones levels. And the highest concentration we received was 1.3 millimole per liter, which is totally fine because this is not a ketoacidosis, this is ketosis. So this is a normal physiological response. So to be clear, no, by solely starting ease off and going up with the glucose target, from my perspective, if sensor readings are accurate and the the infusion is insert, then no elevated risk of ketoacidosis.
Okay. We are 7 minutes more than the intended time, and still we have more than 200 people died. And I think this is a testament to how interested people are. But I want to be respectful of your time, Professor Moser. A lot of the comments that we are receiving at the moment are just thanking you for the practical information. You're really helping people in their practice. I just want to reiterate that this webinar is recorded. You will automatically get this recording via email. And we have a mini survey in the email. So if you could fill it, that would be really helpful. Professor Moser, do you have any final words that you want to say?
Yeah, maybe I use the time when I'm allowed to have final words. So from our and from my perspective, I think the most important recommendation is that all people with type 1 diabetes, independent of age, independent of gender, or where they are living, should be supported to start with exercise and do their entire life exercise, and not just exercise, also being generally physically active. We do see this multipotent drug of being physically active. It's working in your entire body, and we must use it for one reason, that people with type 1 diabetes are getting around 150 years old without any comorbidities, and at the same time with an extreme high quality of life. I think this is the major recommendation.
Thank you so much. Really, we appreciate it. And maybe we should have a follow-up. Honestly, I couldn't catch up with all of these interesting questions. Thank you so much. Have a great day.
Thank you.
Bye.